Welcome to the very last webinar for 2022 from Arthritis New South Wales. So I hope it's a good one. My name is Kat King and I'm the health educator at Arthritis New South Wales. And I have the lovely Dr. Ilana Ingus. Oh, did I say that correctly?
Ingus.
Yeah. That's great. Thank you so much. With me tonight, and she's going to help answering some questions. So Ilana is a rheumatologist who has expertise in treating all forms and types of arthritis, including rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, gout and lupus, and caring for women with arthritis throughout the childbearing years and beyond is a particular area of interest. So it's really lovely to have you on, and thank you so much for giving us your time tonight.
Thank you. I'm excited to be
here. Great. Okay, so a bit of an outline of this evening's session. We're really looking at medication and illness intrusion, and we're looking at a couple of different sections here, or should I say context. So looking at how medication and the illness that you may have, being the majority of you here tonight, is rheumatoid arthritis and psoriatic arthritis, and the effect that it has on body image and self-esteem, family members, friends, and social settings with your sexual partner, and family planning. There is only a few of us here tonight, so I think most will probably participate, or you'll have the option to participate in poll questions like we just did with demographics. But the whiteboard activities may not necessarily lend themselves to a smaller group. So we may look past those and just use the chat box for any questions and answers throughout. Okay, so I want to start here looking at body image and self-esteem, because I feel body image and self-esteem are very prominent themes in those people with rheumatic autoimmune conditions or any chronic disease. And they can have a significant effect on one's well-being, confidence to participate in social contexts, and of course, their sexual health and their sexual partners. Firstly, and briefly, though, I know you'll be intimately aware of your condition and the disease and how it affects you. So firstly, and very briefly, a little bit of a background. So many rheumatic autoimmune conditions like rheumatoid arthritis, PSA, psoriatic arthritis, ankylosing spondylitis, they're very chronic, multi-system diseases, which can lead to, not always, but can lead to disability. Often the disease course can lead to insufficiencies in some body functions and structures, including musculoskeletal pain, being the most common complained about symptom, fatigue, joint stiffness, joint swelling, weakness, joint deformities, and even fractures. And the joint pains and the potential fractures or deformities can reduce our ability to be physically active, which potentially leads us to gaining weight and essentially change the way that our body looks. Medications like steroids, for example, can also cause significant weight gain, where other medications may cause further lethargy or increase fluid retention. And so all these changes, regardless of being temporary, can cause affect changes, reduce self-esteem, confidence in our body image and our body and our self-esteem. So without going on that further, if we have a little look here as to the points on the slide. Women with rheumatoid arthritis are 8 times more likely to have a lower self-esteem and poorer body image than healthy women or women without rheumatoid arthritis. And as mentioned, condition and medication side effects can cause undesirable changes in our body. And in saying that also body image and self-esteem directly influence one another. So when you have a healthy body image, you feel comfortable about your body and you know how to care for it. When someone doesn't like their body, they may not feel good about themselves or take care of themselves very well. And so I guess this is what we want to address first up. And we can see how that body image and poor self-esteem can really permeate into other aspects of life. So family life, social relations, working life, and sexual activity. So the next slide here, and just to provide a bit of background and context, I gathered some feedback from a very small handful of case studies of women, mostly women, who were in their 20s and 30s. I asked some questions, survey questions about their experience with their said diagnosis. Mostly these women were diagnosed with rheumatoid arthritis. And I asked them questions about their body image and their self-esteem. I also asked questions about sexual health as well. So this is one of, I guess, these are some quotes that I have pulled from that small cohort of case studies in regards to body image and self-esteem. Now, we can't generalize this to everybody here tonight and to every young person with rheumatoid arthritis, but you can certainly see, and maybe you may even resonate with some of these quotes tonight. So a theme was, of course, with this small cohort who had rheumatoid arthritis, was that they felt less attractive. So I felt less attractive because I didn't like the way, I didn't feel like my body was really mine anymore. Another one quote was, I just felt unattractive. And this one's a little more long-winded, but I thought very applicable. I gained 14 kilos in 3 months on prednisone, and I was so swollen and full of fluid that I really didn't look like or feel like myself at all. I'd always been quite fit and had never struggled with weight or body issues. So it was really difficult for me to adjust to being on in a body that didn't feel like it was mine anymore. And so that particular one actually was from a woman in her early 20s who had actually been diagnosed with Still's disease, which is a form of rheumatoid arthritis, but more rare and more aggressive, and really, really, really unwell in the hospital. So her experience may have been a little bit more acute, and the amount of medication she was on may have caused significant weight gain. But nonetheless, these were thoughts and quotes from people perhaps like yourselves. And I wanted to draw that to your attention. So I'm curious to know if body image and self-esteem for the people here tonight has been affected, and I guess by their diagnosis. So we'll have a look at the poll question here, and I will launch that now. I'm pretty sure that's question 1. Has your diagnosis negatively affected body image and self-esteem? So I'm going to launch that poll now. Do you resonate with any of those quotes? So we have yes, a lot, yes, somewhat, and another one or another answer to be no. Okay, those answers are coming through now. Okay, if you're curious, so you're not feeling alone, majority of the people here tonight said yes, somewhat. And a few others said yes, a lot. I'm curious to know what aspects about your condition and medication have directly affected your body image and self-esteem. That's something that you may like to share in the chat box instead of us doing a whiteboard. If you wanted to share, you have the time now in the chat box to list or dot point what aspects about your condition and medication have directly affected your body image or self-esteem. So the themes that we picked up before in that previous slide was certainly the weight gain. And it looked to be from perhaps medication or the inability to exercise and therefore putting on weight. Yep, thank you for sharing. Yes, weight gain, probably one of the biggest ones. It's okay if you don't want to write or share, that's not a problem, but I'm certainly offering the opportunity to do so. So, Kirsty, thank you. I agree with the quotes that my body doesn't really feel like mine anymore. And I also don't trust my body as much as I used to. I don't feel confident doing exercise. Yeah, and I can understand why. So you probably feel like you're exercising because you feel good, but then that may end in really sore joints or a flare or something like this. So I can understand the hesitancy there. Fatigue, yep. I got bumps on my knuckles and they make my fingers look terrible. Yep, absolutely. And also some scars from surgery. Yeah. Thank you for sharing, and all really, really understandable points and really valid points.
Can I jump in here?
Absolutely. Just about to call you in.
I'm interested because one of the things I talk with my patients a lot about, apart from those things, is kind of thinning of the hair, or it's a big thing for some of our patients. If the hair, you know, some of the medications or the disease itself might make the hair thinner. That's a big thing that some of my patients talk to me about, and even some of the reasons they want to change their medications. So I wonder if anyone else has had that problem. Yeah,
that's a good point. So thinning hair.
Thinning hair, facial rashes. I mean, these are all things that affect appearance. Yeah.
May not seem so. Is there any anything to do? Oh, I guess you said facial rashes, but is there anything else to do with the skin that some of these medications in terms of side effects?
Yeah, no, I mean, I was thinking also about, of course, some of us on here have psoriasis. So that's we have mentioned that as something that, you know, skin problem that certainly affects men and women's self-esteem. But in turn, the other, I guess, some people that have been on hydroxychloroquine, Plaquenil, might get a bit of pigmentation, sensitivity to the sun. So we're often telling people, you know, be careful about the sun, but, you know, people love going out in the sun. So, but they might get a facial rash or something like that in the sun, or itchy, you know, so all of these things affect our body. Yeah.
That's a good point that you bring up about going in the sun and it being not so great if you're on a certain medication, and then being told that, you know, we need to get some sun for vitamin D and bone health. So I can see there's very competing messages there, and must be difficult to manage. Yeah, so you're right. Well, some people have said hair thinning has been a symptom for someone's daughter for a while with the same diagnosis. Some don't have the hair thinning but get psoriasis on their face, which is embarrassing. And yes, so hair thinning seems to be seems to be common. Thank you for sharing, and thank you for your comments, Ilana. Okay, so very, very quickly, because I'd like to move on to some of the more questions that I'd like to Ilana to weigh in on. But very, very quickly, what are the consequences of a negative body image? And just very briefly, and that's rhetorical because I'll quickly go through that now. So I guess any shift in your body image or self-perception, self-esteem can be emotionally distressing, essentially. And adults who are physically challenged or have noticeable signs or symptoms may feel unsupported by society at large. They become self-conscious in public, or are critical of their own bodies, and can sometimes withdraw and socially isolate themselves. And this distress has the propensity to progress into depression or anxiety. I'm not saying that it will, but you certainly may be at a higher risk. And if your disease and pain and body frustration triggers distress anxiety or depression, it's certainly important to seek help. And while we can't dive deeply into that, we can just quickly touch on how you may nurture a positive body image. So I think it's important to appreciate yourself as a whole person and not to be defined by your illness. And before I go on, I know that all of these things are really easy to say, but can be very difficult to do. So I absolutely recognize that. I think we need to focus on and develop the abilities to feel good about the things that we can do, and not to dwell on the things that we can't. I think not overgeneralizing. So this is using rheumatoid arthritis. If the RA keeps you from doing one thing, don't think that you're an all over failure. So don't generalize that to the rest of your life. I think it's about working towards accepting your body. And there's a misconception here about acceptance being that we immediately think of resignation, and that's just not true. Essentially accepting where you are in the current situation and not continually resisting, because whatever we resist sort of persists. I like that old sort of saying. And it's about accepting where we are in this moment and then allowing you to move through open doors, moving forward, and sort of not denying where you are. And in which case, then you can sort of formulate a plan to move forward. Committing to your body in positive ways. So it can be difficult to manage your weight when you find it difficult to exercise and when you're on medication that may increase your weight, whether it be fluid weight or actual increase in fat mass. But it's still, I guess, important to commit to those habits. So managing your weight through physical activity as best you can within the limitations that you have, and doing activities that promote a positive attitude. So it may not be something that's quite physical. It could be meditation, for example. And surround yourself with people who support, respect, and encourage you. And it's healthy for you to explore body image issues with the people that you trust, because hopefully they're going to tell you the truth and then support you. Okay, so moving on to the effects of socializing, and remembering that cohort of case studies that I had where I asked people with rheumatoid arthritis a bunch of questions, a bunch of survey questions. These were the themes that I pulled out of those case studies in regards to medication, illness, on socializing. So there were two main themes here. One was unable to participate, and the other one was families and friends not understanding. And these are some of the quotes or comments that these people had. So I'd be interested to see what resonates with you here tonight. So some people said missing out on big life events because they were too unwell to travel. So this is how their medication or their illness affects their social life. Became less social because I was no longer able to do a lot of the things that I used to do. So camping, playing sport, going out at night, and in brackets here, because the cold would cause greater pain. And I also wasn't allowed to drink because of my medication, and would often have nausea from eating different foods. So there's significant impacts there. And then when it came to family and friends not understanding in sort of that theme, a comment here was family and friends really not understanding the condition can be difficult. They didn't get why I needed a disabled parking permit, or why I was too exhausted to come to family events or travel for friends' weddings. So we can see how, well, I can see how this cohort of people, I guess, suffer in terms of their socializing ability due to their medication and or illness intrusion. And I guess what I want to do is open it up to the audience here tonight and ask you sort of the same questions to see where we're all at. So if I were to launch the next poll, questions on the screen. Has your condition affected your ability to socialize as you'd like to? So that was yes, a lot, yes, somewhat, and no, not really. And the second question there on the screen, if you scroll, do your family and friends find it hard to understand your condition? Yes, all the time, yes, sometimes, and no, not really. Okay, I'll just let those ones come in. And just 5 more seconds. Great. Thank you. I'll end the poll and I'll share these results. You may find them interesting. So, has your condition affected your ability to socialize as you'd like to? As of the people here tonight, a few, 33% yes, a lot. Yes, somewhat said 50% and 17% no, not really. Does your family and friends find it hard to understand your condition? Some said 17% said yes all the time. Half of you said yes sometimes, and then 33% no, not really. Okay, good. Thank you. Thank you for sharing. So you're certainly not alone when it comes to your condition and your medication intruding on your social life and ability to engage. Alana, is there anything you'd like to comment?
No, I mean, I guess this is, the experience that I've seen with my patients, talking to them. And I think sometimes, when you go to your doctor, it's not something that's even discussed. It's so important. Like often we focus so much on, which joints are swollen or what's your CRP or, oh no, you're much better because your CRP's come down, but actually a lot of people are in this situation and they're not as well as they could be because they can't actually go out and they can't, so it's important for us to kind of, discuss those things as well in the consultations.
Yeah. So I guess we can't look at a chronic illness in just particularly one, obviously this one's physical in a vacuum is what I'm trying to say. So like you said, blood markers might be of a certain level and they're great, but the person in front of you may not be feeling great. And it's because perhaps of these other reasons. So you're right. I think broaching those topics as the practitioner, but even as the patient, the client seeing the professional, what can be done about this? How can you help me, or who can I go to for help? Okay, so thank you for sharing on that topic. And now we move to sex and sexual partner. So once again, we have, I've divided into physical ability and mental health and well-being when it comes to how medications and the illness affects sex health and relationships with our sexual partners. So rheumatoid arthritis, psoriatic arthritis, and similar can make their way into every aspect of our life, including our sex life. So joint pain and fatigue can make physical intimacy extremely challenging and even unpleasant at times, which can affect your libido and motivation to get started. But you can still have a healthy sex life if you have rheumatoid arthritis, psoriatic arthritis, or the like. You might just have to find different ways that work best for you and your partner. In 2018, a study found more than half of people living with rheumatoid arthritis reported issues related to their sex life, like pain during intercourse, a low sex drive, and feeling dissatisfied overall with their sexual health. So it's very common, and this is why we bring it up. And it's certainly something that can be and should be spoken about, even though it can maybe be a little bit awkward to broach the topic with your GP or your other healthcare professional. So these were some physical issues or quotes pulled from my case studies, and these included the lack the desire because they were fatigued or tired. They lacked the mobility and flexibility to make certain positions that maybe they found preferable, attainable. they limited sexual endurance, they lacked strength. And in quotes here, anything aerobic was often out of the question when it comes to the act of sex. And not only does it affect the physical intimacy side of things of sex, it also infiltrates mental health and well-being in regards to your sexual partner. So some quotes here were like, I feel sometimes I'm letting my husband down. Sometimes it causes tension between us. So I guess maybe that person doesn't feel able to or up to or can't do certain things. And lastly, quote, medications I took cause weight gain, hair loss, as we mentioned before, and bruises on my body, which didn't exactly make me feel confident in my own skin. And again, directly affecting their sexual activities. So besides a drop in sex drive, rheumatoid arthritis can sometimes cause other sexual problems. An example being vaginal dryness and erectile dysfunction. So I thought maybe Dr. Ilana, you may have some thoughts on this and what could be done, or what experience you may have with patients who you see about, and if this is brought up, if this is an issue.
Yeah, look, I think genital dryness is a big one, and particularly in women with rheumatoid arthritis or Sjogren's syndrome. And of course, some people that have psoriatic arthritis also have, genital psoriasis. So these are real issues, and often not discussed. And I think when it's brought up, often women are kind of quite relieved to talk about. And there are things that can be done. So there's a lot of things that can't be helped, right? There are some things that can be helped. So things like genital dryness, there are things that women can use to help them, which might be over-the-counter things like Replens. There are sort of ointments, like there's one called Olive and Bee, which is a beautiful natural lubricant that people can use. And there are things that actually can be done to it, just like we use eye drops when we've got dry eyes. There are things that can be done to help genital dryness, particularly while they're having sex. Like that might be one thing that can be improved. But it is a really big problem. And if it's not brought up and it's not discussed, it won't be improved. Yeah.
Absolutely. Something just popped into my head, so I'm really sorry if I've put you on the spot on this one.
No.
I was thinking, obviously in the groin area, sometimes we're hot and we're sweaty, and sometimes different types of materials in terms of underpants can be better, particularly with those people with psoriasis or dryness. Do you think maybe for boys they could wear like boxers, which are quite breezy and stuff, but for female, for women, cotton?
So cotton underwear, particularly cotton gussets, it's really important.
Okay.
Not wearing them too tight. And even, and there's all the other things, so if women have genital dryness, they're much more prone to getting thrush. So we've got to, and then that can last for a long time, and that can cause difficulties. And that's something that is quite manageable, correct underwear, not using soap to wash ourselves. So that's something that's easy to sort out, easy-ish to sort out if it's discussed. And because I speak to women, by the time we talk about it, they're so happy to talk about it. They say, I've had that for so long, chronic, persistent or recurrent thrush. And sort of sometimes they might have a male GP. They should feel comfortable talking to him, but they don't, so these are things that can be fixed.
Oh, that's so good for you to say. Hopefully, if there are people here tonight who have similar or same experiences, hopefully that's given them a bit of a direction, bit of an understanding, normalized the experience, but maybe even helped them or prompt them to speak to their healthcare provider. So I guess on that, since you have and you do work with patients who have that condition or those symptoms, and it's been brought up in clinical consultation, Are there any tips for people here tonight on how they may, if they're feeling nervous, to bring up sexual health?
Yeah. Look, I guess, no. It's really important. I think some women and men have kind of had bad experiences in the past where they've tried to bring it up and they've been, so I guess the first thing is to have the right health professional, someone that you're feeling confident and that you trust, right?
Yeah.
Because
Yeah.
whether it's a doctor, there's all different types of health professionals who can help with it. And I think one thing is don't leave it till the end, right? So we have the full consultation and we've covered everything. And then as you walk out the door saying, but I wanted to talk about this. So just say at the beginning, you can write it down, there was something I wanted to discuss today, which is, I found that I've had a lot of genital dryness, or I found that I'm getting some ulcers, or whatever it is. But sort of just write it down, have it ready, say it at the beginning, get it out there. And I can almost promise you that if you've got a trusted health professional, that's just their bread and butter, normal kind of daily things that we talk about.
Yeah. And that's good for people to hear that's like all of that you're used to, all of that
there is nothing that, it's funny that when we examine people, and it's always women that do this, they go, oh, I'm so sorry, I haven't shaved my legs, or my feet are dirty, or I haven't had my pedicure, or I haven't washed, whatever it is. And it's the same thing. And for us, that is what we do. So we're there to hear anything that, you might find embarrassing. We don't find embarrassing because that's our job. That's what we do.
Yeah.
You can have hairy legs. You can put on what, we don't care about any of that. So that's not important for us as doctors. And that's our job. That's why you're coming to see us. Yeah.
That's right. I think you brought up a good point. An important point is because often, in general practice, seeing a GP is often really rushed. Might be different one-on-one with a specialist. You got a bit more time, perhaps. But I think writing down a list is a really good idea, and go in with that list, and so that you can kind of check those things off. So you got out of the session what you needed. So I think that's a really good point, and thanks for that.
I think also just to add to that, an understanding that often it can't all be fixed in the one visit.
Yeah.
So, and it can be quite overwhelming for like particularly a GP who's in a rush. If you say, and I want to discuss this, and I want to discuss my blood pressure, and I want, so, to come in with the list and say, all right, look, I understand we're not going to be able to cover all this today, but this is the most important thing I want to discuss today. I'm happy to come back next week to talk about my blood pressure, but actually the really pressing thing for me today is to talk about X.
Yeah, good point. So prioritize those things. Absolutely. Okay, great. Thank you. So just very, very quickly on things you can do to improve your sex life. So I think this one here, so prioritizing your sex life. Everybody has the right to sexual health. Everyone's sexual health deserves to be addressed, and you may need to be willing to explore and research and seek professional health, or help, should I say, but it's just a matter of asking. So kind of what Dr. Ilana and I have been talking about. So if there's something on your mind, a doctor or a specialist is a good place to start, and just to have it on that list, and it's a priority for you this time. So bring it up, because that's a very important part of your life, and if you're in a relationship, a very, very important part of that relationship, or it could be, just to be open and honest. So talking to your partner or your sexual partner, because people can misinterpret things. So something like, oh, my knee hurts today, can be interpreted to your sexual partner as you don't feel like doing it today, or you don't find me attractive by your partner. But instead you could say, hey, look, I love you and I want to see you and I want to be with you tonight, but this is a bad day for me with my arthritis. And this way there isn't any sort of miscommunication in that, and there's no misinterpretation. So just ensure that you're open and you're honest. Consider your energy levels. So look, in the morning, often people are just waking up. I feel so stiff in the morning. It's not a good time for me. Maybe it's not a good time for you in the morning. So consider energy levels, consider medication timings as well. And that if you've got more energy, you may actually feel like engaging in sexual intercourse and other activities. Experiment, explore, and keep an open mind. Of some of those case studies and the surveys and the questions in the surveys that I've asked, there was some really healthy relationships going on whereby the partners would be really open with each other, and it seemed to work, and they would experiment and explore on what they could do. And they kept an open mind in that maybe tonight wasn't a night of traditional missionary style sex. Maybe it was intimacy, but in the form of a massage or in the form of using sex toys. So keep an open mind as to what feels good and what you both can do to each other and with each other to maintain that intimacy. I think also it's a really good point, keeping it lighthearted. So if we're having to have a laugh about certain things, a few people of those case studies mentioned while they were having sexual intercourse, they had a huge cramp or they had a back spasm, or not that that's a very nice thing, but you're in the middle of something very lovely or very pleasurable and something like this happens. So just keep it lighthearted, have a joke about those sorts of things, because I find it probably easier to deal with and move on from. And lastly, of course, things we can do to improve our sex life, as we've just spoken with Dr. Ilana, is to talk to your doctor. And last but not least is the last topic of tonight, and that's medication and illness intrusion. And we're talking about family planning. So these are the questions that I had for Dr. Ilana, and I think they're fairly generic and commonly asked questions when it comes to family planning for those men and women who have rheumatoid arthritis or similar. So firstly, it's important to note that people with rheumatic autoimmune diseases, often can have safe, uneventful pregnancies. They're able to adapt their lives and have healthy babies. They can be breastfed and they can be cared for just as any other parent does. It may not always be easy, but it is possible. But of course, RA, PSA, ankylosing spondylitis, lupus, and other rheumatic diseases can increase your risk of complications during pregnancy. An example of that would be the type of medications you may be on. So let's jump sort of straight into those questions. The first few here are, and it may not be a long-winded answer, Ilana, but
yeah.
Women often take longer to conceive.
Yeah, so traditionally and in the past, yes. So women with rheumatoid arthritis were having longer times to pregnancy and smaller family sizes. So we know that definitely. We think though that these days with much better treatment, much more effective treatment, and people having less inflammation, that is not as much of a problem. And we know that if women have, if their inflammation is under control, they are almost just as fertile, or just as fertile. So it's about how active the disease is. And if we can control the condition, fertility should be good, right? So does medication affect egg or sperm count and quality? Egg count and quality, no. I mean, I'm going to take out of this one of the medications, which is called cyclophosphamide, that probably nobody here is on, I presume. But outside of that, the medications that we use in general don't affect egg count or quality. One of the medications might affect, so sulfasalazine or silazepirine may affect sperm count and quality, but a lot of men are quite fertile, if that's the word for a man, even taking that. But otherwise, that is not that is not an issue. So often when women start medications, say it's going to affect my fertility, the answer generally with most of our medications is no. If anything, they might improve your fertility. Best time to try and conceive. So in general, the best time is when your condition is controlled. So particularly at the beginning of an inflammatory arthritis, when there's a lot of inflammation in the body, that can be a hard time for a lot of reasons to conceive. It is done, it can be done, and a lot of women do conceive at that time. But what we aim to do is get things under control, at least partially under control, before attempting conception.
Great. Oh, my apologies. Hold on. Ooh. There we go.
Okay, medication. So does medication need to be stop altogether to conceive? So the answer to that depends on what the medication is. And this, I would hope that everyone in this situation has discussed it with their GP and specialist. We like pregnancies to be planned in this situation, so we have you on the right medications when you want to conceive. Medications that are, so if I have a patient who is wanting to conceive, she'll go on safe medications, medications that are safe during pregnancy, and she'll continue those throughout the pregnancy. There are some medications like methotrexate, a lot of people either on or have been on, well, we do need to stop it about 3 months before. So, but generally women will stay on a safe medication throughout conception. Other factors that can influence the ability to conceive. Well, we've just talked about some of them, haven't we?
Sorry.
So, if sex is hard and difficult and you may not be doing it as often, well, that's obviously going to affect your ability to conceive. That would be probably the most important thing. But I would say, look, the most important thing is that a body that has a lot of inflammation in it is not such a friendly environment for a fetus. So, that's the thing really that can influence the ability to conceive. That's the main thing. I'm not sure if you were.
Sorry. What about NSAIDs or corticosteroids? I guess you're taking them.
Thank you.
But what about those ones?
NSAIDs are really important. So we're talking about drugs like Nurofen or Mobic or Celebrex, those kind of medications. So there is some research that tells us that they may actually reduce women's fertility. So it depends on how important they are for you, So particularly if women are having trouble conceiving or difficulty with their fertility, we would usually say to stop anti-inflammatories, when they're trying to conceive, but that's not true for everybody.
Okay.
And it's really a case-by-case basis.
Okay, great. IVF and when to consider that?
So IVF is definitely an option. I think that it's probably, so it should be considered in a similar way to women that don't have rheumatic disease. There are other things that we need to think about. So things like egg retrieval and things, but it just thinking about assisted reproduction, that's absolutely a case-by-case issue. It depends on age. It depends on how long it's already taken. It depends on whether there are any kind of previous miscarriages and genetic issues and things like that. So that's one that I would definitely say has to be planned, obviously planned and discussed with the GP, fertility specialist and the rheumatologist. What health professionals can help, we could talk forever about this because obviously the GP, as I see the GP as the kind of the central kind of person, like the conductor of the orchestra, and they really should be your first port. But obviously the rheumatologist should be involved. We've got to have you on the right medications. But the other kind of, allied health professionals can be really, really useful. So, for example, if your problem is fatigue and low endurance and, problems with motivation, although so exercise physiologists can be really useful. Pelvic
Mm-hmm.
floor physiotherapists could be really useful in some settings.
Yeah.
And there may well be a team that's needed if you're having issues with fertility.
Okay, great. Thank you. We'll move on to the next one where it says, now you're pregnant, now what? And I just wanted to bring a touch back to medication. So when people are pregnant, I guess you've already changed their medication so they can get pregnant. So I'm assuming they still stay on the same medication that's safe. But I just put this up, and you don't really necessarily need to talk to it. But if you've got any comments, yeah, go ahead, Alana.
Yeah, so I mean, this comes, I think, from the recent guidelines that have come up about pregnancy, and what I want to say. So this is absolutely true, and this is what we follow. What I want to say is you will get different opinions from different people, and just be careful. Like, so not everybody is familiar with this stuff, right? So there are even some GPs that might not quite understand, for example, that you can safely be on sulfasalazine or you can safely be on TNF inhibitors. Not all pharmacists would understand it. And so it can make people a bit confused. You know, my rheumatologist said this, but my pharmacist said it's unsafe. So, you know, there are very clear guidelines. Not everybody knows. You know, not every health professional is familiar with it. And if you've got any doubts and you're just really not quite sure, I would absolutely recommend MotherSafe, which a lot of my patients are in contact with a lot. So MotherSafe is what it's called. And they're nurse counsellors whose main interest is helping you with medications in pregnancy and breastfeeding, and you can ring anytime. So, but yes, this is the guidelines that we follow.
Perfect. Thank you for clarifying that. And I think that's a really important point you bring up about competing ideas or beliefs between the professionals. It's always such a confusing time, but I think the fact that you brought it up is important. And if the rheumatologist is providing information from this, you know, well-known base of information that's been tested, then hopefully that is the way to go. Okay, I think this is our last slide here. So still on your pregnant now what? I hear different things when it comes to symptoms while pregnant. So do my symptoms get worse? Do they get better? I'm assuming that it's very individual. But yeah, what's your experience with this?
Okay, so we know, and this is RA, and psoriatic arthritis is probably similar, but if you're lucky, your symptoms will get better in pregnancy. We used to think, you know, oh, every woman with rheumatoid or psoriatic arthritis gets better in pregnancy. That's not true. So it's probably something like 60% will improve, and often significantly improve. You know, people can feel great in pregnancy. Probably roughly, you know, 20% or so will stay about the same. But then there will be 10, 20%, something like that, who will get worse, right? So depends on the condition, and it depends on the individual. People, you know, can get flares, and if you have a flare, we treat it, you know. So we treat it with, it might be a short course of prednisone, it might be a steroid injection, it might be anti-inflammatories if it's at the right time in pregnancy. And we don't think having a flare will harm the fetus. You know, fetuses or babies are very, very surprisingly resilient. And there's no evidence that causes any problems. Can I carry to full term? Most women will have a normal length of pregnancy. Sometimes babies come a bit early. Sometimes babies are a bit small, you know, smaller than expected. But we would expect these days, with, you know, someone with controlled disease on the right medications would pretty much have a normal length and quality of pregnancy.
Great, good to know. Okay, come the delivery day, I'm curious to know, are there any sort of special considerations, or are there any complications that you may know of?
Yeah, so yes, there are. So with some of the rheumatic conditions, women are more likely to, you know, have issues towards the delivery day, like blood pressure or, you know, other medical issues. A lot of it, in terms of the delivery, there's a few things that it depends on. So one thing is you know, where your arthritis is. So if you've got very bad hip arthritis, for example, really stiff hips, it's going to be tricky to have a vaginal delivery.
Yeah.
Now, that doesn't mean that everyone with hip arthritis can't have a vaginal delivery, not
No.
at all. But there will be some that is just it will be too uncomfortable for them. Some women have had juvenile arthritis. So often women with juvenile arthritis will have smaller pelvises and more. So those are the kind of things that we would think about. For most women like that I would see with rheumatic conditions, they are quite able to have a vaginal delivery unless there's some sort of complication.
Right.
And what's the Koebner phenomenon? Yeah, so I presume this you're referring to the Koebner phenomenon with psoriasis. Is that the?
Yes, I did see in somewhere, and I guess that's why I just threw it in case it was relevant. But yeah, it can happen with those who have psoriatic arthritis.
Yeah, looks the Koebner phenomenon is when someone with psoriasis tends to get psoriasis at a place where there's you know, an injury or the skin tear or friction or something like that, and they get more psoriasis. So it is something with women with genital psoriasis can get, you know, more lesions or more of a rash around the genitals around delivery, but I think it's probably pretty rare. And if you do have genital psoriasis, that's something that the obstetrician would need to know.
Yeah. Okay, great. And lastly, here we have post-delivery. So after I deliver my baby, what happens in terms of medication? Do I go straight back to my other medication that I was on, or what happens in that context?
So again, it depends on the medication. But the safe medications we're talking about, the medications which we are saying are safe in pregnancy, are generally safe in breastfeeding.
Excellent.
And so the only issues with that is if, for example, if you had a cesarean section, and we may not start you straight back onto an immunosuppressive drug. We might wait and make sure that the wound is healing normally, for example, right? If and because of these medications that we're talking about are generally safe with breastfeeding, the only caveat to that is if bub comes out early, sort of premature or unwell, sometimes their gastrointestinal system is not quite mature. And so there are some medications that we may need to wait a little bit before we start. But in general, most of my patients, I say, you know, they deliver and they have their first shot of their medication because that's kind of and the reason for that, so are there increased flares? And the answer to that is yes. So it is quite common to have what we call postpartum flares. So after delivering in the first 3 months, women are more likely to get flares of their condition. But if they've got their medications on board, that's much less likely. So often the earlier we start it, the better. Can I breastfeed? I've kind of touched on that.
Yeah,
so yep, safe medications, safe with breastfeeding. Will my baby develop arthritis? So in general, there is no issue with the baby developing arthritis. There are a couple of, and I'm not even going to talk about them now, there are a couple of conditions where there can be issues with baby early on, but these are not them, right? And your baby, you know, it's something like rheumatoid arthritis. There is a slightly increased risk that when your baby is an adult, they may have an increased risk of rheumatoid arthritis, but by far the most likely thing is that they will never develop rheumatoid arthritis.
Oh, good. I think that would be, people would appreciate to hear that. Yeah. Although is there genetic or hereditary links in rheumatic conditions?
And there are, but we're talking about conditions that are not that common. So if and let's say we've got a condition that happens in 1 in every 100 people, and then you have an increased risk, and now it's 2 in every 100 people or 3 in every 100 people. It's not a direct genetic disease, but there are families where there are increased members with the same condition.
Yeah. Okay, well, that brings us to the end. So I'm asking anybody out there tonight if they have any other last questions, or not last questions, but yeah, questions that you may like to ask while we're still here. And I may sort of stop this share as well. Oh, there we go. And bring us back to the main setting here. So are there any questions that we may like to ask? If you want, you can use your mic or you can put it in the chat box. I'll give you just a couple of seconds to put your hand up or type away. I don't think there are any other questions tonight. You were so great.
We answered everything.
Everything.
We shocked them. Yeah.
We absolutely did. Look, we covered a lot. But yes, thank you so much, Dr. Ilana, for your time tonight and answering those questions. I know they just kept flying at you.
Okay.
And so well, thank you so much.
My pleasure. Absolutely. Yeah.
And for all those here tonight, I hope you enjoyed the session. This will be recorded, so you can always come back and watch it. It'll be available on our website. So that's it for tonight. Thank you, everybody, and good night. Bye-bye. See you later. I'll end this session now.